Thank you, Professor Zhang Fujie, for your introduction. I feel humble in front of such a warm introduction. So, dear colleagues, good afternoon. My name is Sun Lijun. I'm from Beijing Yuan Hospital of Capital Medical University. I'm from the infectious disease department. So I will talk about antiviral treatment in pregnant women with HIV and neonatals. So this is my index of my presentation. Firstly, prevalence of women living with HIV. Second, antiviral therapy in pregnant women with HIV. And thirdly, neonatals. So we know that by July of 2020, there was a population of 20 million for women infected with HIV, and most of them actually are in the period of children bearing potential. So you can see that about 50% of them are women, in particular for the sub-Sahara region. 60% of the HIV carriers are women, and including 18% of the adolescent women. So that means about 5,000 new infections among younger women, and compared with some adult. You can see that women tend to do better for those above 15 years old in terms of reaching the target of 395%. So you can see that for women with HIV, you can see that the diagnosis rate and the treatment rate, and also the viral suppress rate is much better than men. And for China, what's the situation? So the current status is that 95% of the HIV/AIDS is transmitted by sexual behaviors, and also we have higher and higher incidence in the children and in the elderly population, and the proportion is 3 to 1 for the patients diagnosed with HIV/AIDS. And the second part of my presentation, antiviral treatment in pregnant women with HIV. So for the family with one of the spouse with HIV/AIDS positive, they may have a strong wish to have baby as well. So this is the human's right. This is the right of the people living with HIV to have children. So we have done a good job in China. So for the women with some children bearing potential, we provide free screening for the pregnancy. So you can see that when the people get married, they have the benefit of having free screening, and also when they get pregnant, they also have the benefit to receive free screening. And also we have to emphasize that the HIV positive the person of the family must be must be completely virally suppressed. And also for the men, they should do something like the foreskin resection, circumresection. For male positive male and negative women or female, it is pretty easy to be accepted by the medical institution. However, for the women positive women's side, it may be pretty difficult to be accepted by the medical institution. And here you can see that if the viral load is lower than the 200, we can reduce the infection for the fetus and neonatal, and also reduce the exposure to the healthcare professionals. So what's the time span? So ideally, the pregnant women should be viral load undetectable for at least 3 months continuously. Of course, if you don't have the good resource, you just have one test in 1 month. But ideally, you should have a negative report for continuously 3 months. You can see this is 052 at the partner study. They emphasize that the viral load lower than 400 or 200, the condomless sex will not transmit HIV/AIDS. And also there is another retrospective study. So you can see that some of them had a PrEP, some of them had a PEP. There was no report of HIV transmission. And also this is the report by WHO. If the infant is going to be fed by a breast up to 2 years, you can see that 5 to 10 babies would be infected during pregnancy, and 10 to 15 babies will be infected during labor delivery, and 5 to 20 babies will be infected during breastfeeding. So if you see this kind of situation, you have to understand that it's very important to suppress the viral load in the pregnant period. So if the women is diagnosed as HIV positive, we have to initiate ART as early as possible. And we also need to consider adverse events, DDIs and PKs, and also the teratogenicity, resistance, and comorbidities. And we have to suppress the viral load under the limit of detection. If not good, we should adjust the regimen as soon as possible.
If they are already on ART, then you can maintain the original regimen. If there are PD or PK changes, then you switch the regimen. For pregnant women, we always need to test the viral load. It's a part of the performance evaluation of healthcare organizations, because there are 2 viral load studies free of charge for pregnant women. Also, it's covered by healthcare insurance. Initially, there should be monthly viral load study, and before delivery, it should occur more frequently. Here are the 5 top guidelines frequently used. One from US CDC, one from WHO, one from IAS USA, one from EACS, and the last one is Chinese government. The preferred regimen has always been the NRTD plus TDF, and for the NVP is not that used frequently. And alternatively, you can use ATV, and in Europe, it's more conservative that TAF has been used for pregnancy above 14 weeks. The addition of protease inhibitor has been used in other countries. And for China and for LPV, it's been provided in certain locations. For example, in Beijing, during the mid and later trimester, then they are able to receive 2 NRTIs and the DTG. This regimen has been the first line in the US as well. So across the board, you will see Europe has been more conservative, that DTG should be given only after the 8th week. Overall, China follows the US guideline more oftenly. The initially after pregnancy, it's ADT and TAF. Specifically for EVG, it's common for adults. And when you think of transition, you need to monitor viral load because there are PK issue and the transmission through the placenta. This all affects the infection likelihood of the fetus. On the right side board, there are women of childbearing age who have not developed pregnancy yet. Then the regimen is also two NRTIs and an integrase inhibitor. And you can also individualize the regimen based on patient's needs. This data and regimen has been based on the DHHS guideline 2021. After the report of neural tube deformity issued in 2018, after 3 years, we have clarified that the risk is irrelevant to DTG. So DTG is routinely recommended for populations across the board. For the mode of delivery, initially, people thought that they should deliver the baby with a cesarean section. However, the latest guideline said it is not mandatory that they go through C-section. They can still go through vaginal delivery, and the patients would also have their second or the third child. So it is easier to manage their future potential for delivery when we use vaginal delivery. If you still, if an C-section, whether it's C-section or vaginal delivery, you need to plan it properly and have it as a elective manner to avoid emergency C-section. And you should involve a multi-team, multidisciplinary team to manage patients. 12 countries in the world has put forward the aim of removing certain communicable diseases among pregnant women. In 2022, China would be the host for a global meeting on women well-being, and we will talk about eradicating several communicable diseases among women. They include infection of neonates with HIV. Currently, it's at 3.5, and we should keep it below 1%. And for syphilis, we are standing at 50 per 100,000, and Beijing should be a pilot zone in eradicating those infections during pregnancy and infant. I am quite nervous about these targets because we need to work very hard to eradicate those birth-related transmissions. If one positive infection is identified at birth, or you are not sure whether they are negative, then you count weights and you need to initiate the ART as soon as possible. This is managed by the obstetricians and communicable diseases services. Then you test for CD4 count, viral load, and epidemiological history. And it is always safe to regard them as infected or positive, and then provide therapy until we are sure with the workup results that they are negative. I've seen two cases where the baby had an infected status 7 days after birth, and the baby has already received breast milk. So For the third trimester and also perinatal scenario, you should not wait. We should provide upfront therapy. For the issue of breastfeeding, initially we avoid breastfeeding at all costs, and we recommend artificial feeding. However, the recommendation has changed. It is contraindicated for women with high viral load or women who are not on regular ART. If they demanded and insisted on breastfeeding, for example, in the remote and rural area, then the mother should be on ART and be compliant because we need to reach the U equals U target. We are doing a study to see whether this is safe enough. If the baby is born in a emergency C-section scenario, then it is more difficult to control the breastfeeding issue. Also, we need to monitor the viral load of the neonates and the mother, even though they are on a medication, and we should monitor the liver and kidney function as well. I remember there are two cases. One of them had an anemia and stayed in the hospital for 1 month with liver function damage. Therefore, we need to monitor their liver and kidney function. The third part is follow up on prophylaxis or antiviral therapy for exposed neonates. So neonates are categorized by level of risk. For the low risk, then they use 4 weeks of ACT. In the past, it was 4 to 6 weeks, but currently we have simplified it into 4 weeks of ACT. The second tier is a high risk. That means the mom has not been on regular ACT with a viral load above 50 copies per milliliter or acute or primary HIV. In such case, we need a 3-in-1 treatment regimen. It is ACT plus 3 TC. And we have all these regimens available. For example, the Kelacha. For the RAL is not available yet, but we may expect that in the future. If it's a newborn with HIV and confirmed with positive virological test, then we use 3 drugs, ACT plus 3 TC and NBP. In the future, when RAL is available, we can also use that when the child is more than 3 kg in weight and 4 weeks in birth age. Alternatively, we can use Kelacha. I noticed an interesting finding that the DTG is grinded and separated into 3 doses to use. And so in such case, the DTG is used as an RAL. This is an option when the child is above 3 kg in weight and 4 weeks in age. You can use the same method for several types of tablets. Some are worried about the PD profile. We talked about it among the experts. For example, in the Peking Union Hospital, the nurse have grinded the tablets quite often when administering it for infants. And for the NVP that you are quite familiar, it's weight-based. And then for the infants with higher level of exposure, then you tailor the dose according to the fetus age and birth age. For the group of particularly high risk, with the RAL, and it's based on weight and age. If you are not sure, you can always refer to this tool. For the HIV positive neonates, we need to follow them, and there are follow-ups when we need to test them for antibodies and NAT. The guidelines mentions 18 weeks, and we know that around 90% of them can become negative after 12 months. And there are also I saw cases when they turn negative until the 26 weeks. Therefore, we need to monitor the viral load, and you can spread the test apart. If there are two successive negative results, then you can arrange BCG vaccination for the infants. And also, it's an issue whether you document that in the neonates health screening card. We have seen two cases when the mothers had the infection, but the infants overcome the infection. But the healthcare professionals document that in the neonate health card, which became a barrier for kindergarten and school enrollment. So it creates a lot of controversy and issue if it's not handled properly. So we need to keep an eye on the follow-up. And I wrote a paper about this. It was quoted by other studies as well. So I look forward to have more communication with you, whether online and offline. Thank you.